of October 2024. Uh, Today we have a very, very important topic, and I would like people to, if they want to join, they can join this Zoom meeting at 818-8591-1572, or they can also post their questions. We have Dr. Padma Shri Ganesh Mani. He's joining in for a very important topic, cardiac surgeries in elderly. Dr. Ganesh Mani is an Indio Cardio-Thoracic and vascular surgeon reported to have performed over 20,500 coronary artery bypass surgeries with over 40 years of experience. He has been honored by the Government of India in 2013 Padma Shri Award. It's the fourth highest civilian award for his contribution to the field of medicine and medical education. He's a chairman and director for Max Super Specialty Hospital in New Delhi, and he's a managing director for Mani Heart Care. So we are blessed to have you here. Over to you.
Thank you, Saurabh. It's wonderful to be joining you, reminded of my days with your dad, Dr. K.K. Agarwal, a colleague, Padma Shri, and a great contributor to medicine in India, especially in medical education. So I'm very happy to be part of that.
Thank you, sir.
So let me not make much ado, and let's get started with the topic. I'm doing my screen share, so is that all right by you?
Yes, absolutely.
I think he is not the co-host yet, so you might not be able to share.
No, I think it's open for everyone.
Okay.
Well, here we are. I wanted to talk to you about the importance of the heart team. As you know, cardiac surgery is not a one-man show, and certainly cardiac surgery in the elderly requires the heart team and not the cardiac surgeon alone. Heart team, ladies and gentlemen, involves three specialties. One is cardiac surgeon, of course. The second is the cardiologist. The cardiologists have to operate along with the cardiac surgeons to make it possible. And the third is the cardiac anesthesiologist. So this is how we work in the Max Smart Super Specialty Hospital, which is located in the South Delhi in Saket. And I'll just talk to you about the incremental risk factors for cardiac surgery. Green को बंद करना, उसको क्लिक करो, अभी चला दो. That'll keep coming, is it? Okay. Life expectancy beyond 90 today is becoming a reality. Age per se is not a risk factor for cardiac surgery. It is the timing and the comorbidities of the patient that make a difference. Timing, like urgency of the surgery. Suppose I've been asked to come on a Sunday morning or Christmas night to do surgery, and that has to be done urgently. So I am at a little disadvantage. This is one big disadvantage, especially if the patient is in cardiogenic shock on a balloon pump or is continuing with the CPR going on. That is called urgency of surgery. And nowadays, what is happening is everybody who goes to the cath lab gets a lot of antiplatelets, especially ticagrelor. So this is again a problem that if you have to operate on a patient who has recently been given ticagrelor, and as I said before, required to be done after office hours. These are all risk factors for the patient, especially the elderly. Comorbidities, frailty, osteoporosis, COPD, smoker, asthma, diabetes of long duration, especially if it's uncontrolled, the HbA1c being more than 10, nephropathy, either latent or manifest, associated cerebrovascular disease, maybe there has been a history of stroke, morbid obesity, body surface area more than 30, coexistent malignancy, especially if the patient has prior surgery or chemotherapy or radiotherapy in the past. These are all going to affect the outcomes of surgery. Anemia, nutritional anemia or associated with gastrointestinal disease, either peptic ulcer or bleeding piles or Crohn's disease, hyperproteinemia. These are all situations that are more common in the elderly than in the youngsters. Surgical complexity could be a risk factor too. Patients may come forward for cardiac surgery with coexistent cardiac issues like coronary artery disease with concomitant valve disease, severe aortic stenosis, severe mitral regurgitation. These are concomitant valve disease. Previous heart surgery, if the patient is already in a redo status, he's had a bypass surgery or has had a mitral valve replacement or has had an aortic valve replacement, especially if there are retrosternal adhesions, which are seen in the CT scan, a location of the internal memory artery graft if it's been placed behind the sternum. These are situations which affect it contribute to the incremental risk factor. Calcification of aorta. Sometimes as age advances, our aorta gets calcified and it precludes proximal anastomosis. Unstable hemodynamics, if the patient is dependent on an intra-aortic balloon pump or inotropes or having severe arrhythmia, ventricular tachycardia or recurrent ventricular ectopics. Then severe diffuse atherosclerosis needing single or multiple endarterectomies. Endarterectomies means we remove the intima along with the portion of the atheroma. So this results in vascular bed without an intima, and that is more thrombogenic. This is a risk factor. Previously implanted pacemaker. If the patient is already having a pacemaker, to do surgery on the person who has got a permanent pacemaker has to be taken care of, especially in beating heart surgery. And if the patient has had a previous TAVI, as I'll be talking to you later in the day, the transcatheter aortic valve replacements. And these patients, if they come forward for surgery, especially in the age, about the age of 80 or so, they become risk factors. Anesthesiology concerns in the elderly. One is the poor respiratory reserve, coexistent nephropathy, especially if the creatinine is raised. I mean, there are various levels of creatinine that people take as normal. Roughly, we take it as 1.5 as the cutoff. If a person has got a higher creatinine, then we say that he is having, nowadays, of course, there is EGFR, which is a more accurate method of establishing nephropathy. Carotid artery stenosis, a stable or unstable plaque in the carotid artery. Either we do a carotid endarterectomy along with the surgery, or we do a stenting immediately post-op. Uncontrolled diabetes, especially presence of ketone bodies. Allergies, either declared or undeclared. Compromised hemodynamics, that is if the patient is on pre-op intra-aortic balloon pump or inotropes. Coexistent spinal diseases. Some patients come forward with ankylosing spondylitis and they are not able to extend their neck. So intubation, especially for the anesthetist, becomes a problem. And if he is not declared his dental status, sometimes in a rushed intubation, you can dislodge the dentures. Coexistent hepatic dysfunction. In these days of viral hepatitis, HB, HC, and HE, and also diseases like AIDS, coexistent hepatic dysfunction is a common thing. Coexistent malignancy. These are all situations which add to the anesthesiologist's concern for getting the patient through surgery. The present indication I'll take on, basically I'll be talking on two different topics. One is the valvular, one is the coronary surgery and one is the bypass surgery. Percutaneous catheter intervention with stents is the primary choice of patients as well as cardiologists due to it being less invasive. Increasing longevity may lead to more patients being referred for CABG. Calcified long stenosis and chronic total occlusions may not be ideally suitable for cath lab interventions. So as a result, these patients come for coronary artery bypass surgery. Furthermore, they may have had multiple stents in the past. If they have had stents in the past, they've already had a go, and especially if they are having a tendency to have instant restenosis more commonly than others, then they are referred for surgery. Most of the post-operative morbidity in the past might have been primarily due to the usage of cardiopulmonary bypass, which had accentuated comorbidities. These days, especially in MACs in India, off-pump surgery has become more prevalent, and thereby the elderly have a better prognosis than they had in the past. Off-pump is the preferred choice today, notwithstanding their comorbidities. Hybrid procedures, especially using robotic left internal mammary artery to LAD and stents to circumflex and right coronary, are becoming an option. Today, acute coronary syndrome patients who are brought in, they have to reach the cath lab within 8 to 9 minutes. They are treated aggressively. And suppose they find critical left main disease or advanced triple vessel disease with multiple stenosis, then the cardiologist would probably dilate the culprit artery, which is reperfused, and then they send them for surgery as soon as possible. So then we are asked to do surgery almost immediately. I told you about off-pump surgery. For those who are not familiar with off pump surgery is that when we stabilize the heart while it's still beating, we stabilize a localized area and do it without the usage of extracorporeal circulation. In the past, most bypass surgeries were done on pump, and the complications were relatively due to extracorporeal circulation related causes. What happens in extracorporeal circulation? You generally have a non-pulsatile perfusion and complement activation, which causes a systemic inflammatory response. This could manifest as a stroke because of cerebrovascular coexistent cerebrovascular disease, either major or minor, or uh, inevitable cerebral edema because of hemodilution. These may result in neurological deficit. Patient could have a renal failure again because of the same reason, non-pulsatile perfusion and complement activation. They may require dialysis and CRRT. I'm talking about situations when patients are necessarily done on pump, either because it is the custom in the unit or because the patient is unstable and we have to do it on pump. Pulmonary complications require longer period of ventilation. Bleeding tendencies, especially with recent antiplatelet drugs. What happens with recent antiplatelet drugs on board, and then patient is subjected to cardiopulmonary bypass, which is again traumatic to the platelets. So the bleeding tendencies are more. Anemia requiring more blood transfusion, because if the patient is anemic and is hemodiluted, his anemia will become worse. So he may require more blood transfusions than he otherwise would require. Hypoproteinemia and low osmotic pressure in the blood may need albumin transfusion, albumin infusions. And the systemic inflammatory response is of greater importance in the elderly, as inadequate blood supply occurs to the brain, liver, kidney, etc. when they are on the cardiopulmonary bypass. Of course, we protect them with hypothermia, but sometimes the systemic inflammatory response get aggravated. The non-pulsatile flow for long periods to the pancreas may aggravate hyperglycemia, necessitating intensive glycemic management. Again, going back on the benefits of off-pump surgery, possible use of smaller incisions as we don't require cannulae, lesser dose of heparin, resulting in lesser bleeding from operative site, needle hole bleeding, these are all less. Lesser use of anesthetic drugs because drugs are not lost in the bypass tubings. Lesser requirement of insulin, as I explained before, because the pancreas continues to receive pulsatile perfusion. Lesser incidence of stroke, same reason. Perioperatively, especially in porcelain aorta and all that, we can use a non-touch technique when we don't handle the aorta at all. In that situation, we harvest the left internal mammary and also the right internal mammary artery and use it as a Y graft to graft all the coronary arteries. Lesser incidence of renal failure, especially as pulsatile flow is preserved throughout the procedure. Lesser gut edema and paralytic ileus. Lesser extravascular lung water, thereby requiring lesser periods of ventilation. Lesser myocardial stunning and low cardiac output status. So, because of all these benefits of off-pump surgery, today, at least in India, I would say, off-pump surgery is the preferred modality. In certain situations, bypass cannot be avoided. If we can do off-pump surgery for some bad patients, why not do it for the good patient? Why not do off-pump surgery all the time? There are certain situations where you cannot avoid the bypass. That is, if you have to concomitantly do an aortic valve replacement or a mitral valve replacement, or you're dealing with a ventricular aneurysm where you have to open the ventricle, take out the clot, and repair the ventricle. These are situations where we cannot avoid bypass surgery. And of course, it is a nightmarish situation, especially when patient comes with a ventricular septal rupture, post-infarction, and is in torrential left to right shunt and heart failure, and maybe severely compromised in the lungs and maybe on a ventilator. Now, these are situations where you cannot avoid cardiopulmonary bypass. Ventricular arrhythmia, atrial fibrillation with a fast ventricular rate, this again, beating heart surgery is not possible. Or if they have conserved congenital heart disease, especially if somebody is having a ASD which he didn't know about it, or he has a large PFO, we have to close the PFO, especially when we are doing heart surgery. And then we elect to do it on pump. Even in these situations, the bypass time and the aortic cross-clamp time, we make an attempt to curtail it by doing the bypass grafts off pump and then restricting the cardiopulmonary bypass to minimum, which is required for intracardiac surgery only. Now we go on to the, should I do both the topics together, or you want to ask me questions on coronary artery bypass surgery and then we can move to valve? Which way?
So I think we can cover the topic and then we can ask questions at the end.
Okay. Calcific aortic stenosis is another problem which is very common in the elderly. Almost, I think, all of us as we age, there is deposition of calcium in the aortic valve, more so if we have a bicuspid valve. And today, calcific aortic stenosis is more common because longevity is more. People are living for longer. So more people are coming forward with calcific aortic stenosis. Surgical aortic valve replacement, SAVR as we call it, is the sine qua non of calcific aortic stenosis. Today, there has been advancement that we can do it by transcatheter route, and this is called either TAVI or TAVR by some people. It becomes a preferred option over the age of 65. 65 is slowly getting 70 because 65 patients are quite at a low risk. In India, though the standard of care in low-risk patients of all ages is surgical valve replacement, the standard of care in high-risk patients is transcatheter aortic valve replacement. The patient in the intermediate group are individually advised on a case-to-case basis. Saying that the patient wants to have a TAVI or a TAVR should not be the deciding factor. It is the heart team and the heart team alone which advocates the optimal therapy as per updated guidelines. Saying that the patient wants to have TAVI, that's why we are doing TAVI, is an old practice, and we discourage that today. The standard aortic valve replacement is by the mid-sternotomy, a straight cut across the sternum. But now it can be done as by a mini sternotomy, where you only use the upper half of the sternum, or by a very small thoracotomy. Of course, we have to use cardiopulmonary bypass and cardioplegia. And of course, doing a surgical valve replacement requires multiple sutures and knotting, and this takes more time and more expertise. In the absence of serious comorbidities, it carries a risk of 1% or less, and a procedure of choice in low-risk patients. So doing TAVI for a low-risk patient is not recommended. There are situations, even in the elderly, when the heart team would review the anatomy and deliberately recommend surgical valve replacement in preference to transcatheter aortic valve replacement. These situations are narrow aortic root, say 19 millimeter or below, bicuspid valve with a low coronary height. Sometimes TAVI is not suitable if the coronary height is very low, very close to the annulus, and this can cause the TAVI valve can cause obstruction to the coronary orifice, and you can have a problem on the cath table. Sometimes left ventricular outflow tract calcification dilate the aortic valve. Either there is embolization of the calcium from the left ventricle, or very rarely it can cause an aortic annulus rupture, and this is again a fatal complication. Recently, I was talking about putting these knots, and as you can see in the diagram, there's so many sutures to be put to anchor the aortic valve. Recently, we have had a combination of this TAVI concept in the surgical field, where we get a sutureless valve. Of course, we open the chest and open the aorta and remove all the calcium, and then we can put a sutureless valve, very much like the TAVI, of course, a little smaller. And the advantage is that you save a lot of time. Each time you do an aortic valve replacement, you have to cross-clamp the patient for a long time, and you have to tie these various knots. So the sutureless valves saves time, and also it's useful in narrow aortic routes where there is not enough place to tie the sutures and knots. Treating calcification, calcific aortic stenosis by transcatheter aortic valve implantation. Normally, this talk should have been given by the cardiologist, but since I am part of the heart team, I'm just informing you where we crimp a bovine or porcine valve and it's delivered through the groin, positioned in the calcified annulus and expanded either by a balloon or by self-expanding 19-ounce stent. A brief period of rapid pacing may be required. Deep sedation may suffice, but sometimes many of us prefer general anesthesia because the patient should not get agitated and give trouble during the procedure. These are situations when heart team would prefer TAVI over SAVR. I told you in the earlier slide about why we prefer SAVR over TAVI, and this is the situation where we prefer TAVI over SAVR. Super seniors, patients who are having a low expectancy. Today, if we say that 90 is life expectancy in the United States and about 74, 75 in India, Super seniors over the age of 80, we would say that we would electively offer them TAVI. A redo status, especially a patient who has had a bypass surgery and he has got patent coronary grafts on the aorta, we would use balloon expandable TAVI rather than going in for either surgical valve replacement where you involve disconnection of the aorta and re-anastomosis, etc. Coexistent renal artery disease. If there is renal artery disease, we electively tell them not to go for bypass, because bypass can precipitate hemodialysis earlier. So in that situation also, one could offer them TAVI. Extreme COPD, a patient is not fit for anesthesia, especially a prolonged anesthesia, then we electively tell them to go for TAVI. Coexisting malignancy, of course, subjecting them to a sternotomy is less kind, and therefore we offer them TAVI. Once again, I reiterate, this is the choice of the heart team, and this should not be the choice of the patient. Indications and contraindications. To summarize, if there is coexistent mitral annular calcification, mitral annular calcification is a situation when, because of calcium in the mitral annulus, surgical excision of the mitral valve becomes very risky or rather dangerous because it can cause atrioventricular disruption. In that situation, if a patient presents with calcific aortic stenosis, we would say rather go for TAVI. Isolated AR and aortic ectasia or ascending aorta aneurysm, surgery is the choice. Narrow aortic root, already explained, surgery is the choice. LV outflow calcification, surgery is the choice. Low coronary ostia surgery is the choice. Bicuspid aortic valve with high coronary ostia, one could do a TAVI, but in low ostia, when the ostia are very close to the annulus, we tend to do surgical valve replacement. Of course, between green and red, there are many shades of amber. So sometimes we stretch our indications either way. Of course, with total concurrence of the heart team, both aspects of the team, the surgeon as well as the cardiologist. Treating calcific aortic stenosis in the elderly. There have been trials, worldwide trials, partner trials, 1, 2, 3, have claimed non-inferiority of TAVI to SAVR in high-risk patients and even intermediate risk patients. I think my own personal feeling, it is unethical to offer TAVR or TAVI in low-risk patients, especially young patients who have got more than 10 years of longevity, because these valves which are crimped and then expanded, they may not last 10 years, and subjecting them to SAVR later on becomes a very difficult job, as I'll explain in the subsequent slides. Logic of surgical valve replacement in low-risk patient is, number one, TAVI after SAVR. That is, after a surgical valve replacement, if you have to do a TAVI, this procedure is called valve-in-valve. It's a very simple procedure and it carries a low risk. Surgical valve replacement or a re-TAVI after TAVI is a relatively higher risk. If patient develops coronary artery disease later, both percutaneous catheter intervention as well as bypass surgeries are more difficult, though it is possible. We can use Lima-Rima-Y. And if it's a balloon expandable TAVI, which has been done in the past, then also bypass surgery is possible. The rational approach for lifetime management of severe aortic stenosis would be either surgery or TAVR. Most of the time, as a surgeon, I would recommend, excuse me, I would recommend surgical valve replacement as the first procedure, unless otherwise contraindicated. If you do a mechanical or a bioprosthetic valve, mechanical, you're okay for a lifetime if you're on anticoagulant. Of course, some people can argue, that in elderly patients, we should offer them bioprosthetic because they can have spontaneous cerebral hemorrhages, intracranial hemorrhages. Bioprosthetic, and then if you do a TAVI, the logic of doing a bioprosthetic is that the second procedure can either be a redo surgical valve replacement or it could be a TAVI in SAVI. The third procedure, I'm talking over a period of 25 to 30 years. If a person has a life expectancy of that much, then we are offering them surgical valve replacement. However, if a patient has got a limited longevity, then TAVR is the procedure of choice. As I'll tell you, the TAVR in surgical valve replacement is very easy, whereas reoperating on a surgical on a patient who has had a implanted TAVI can be very, I would say it's a nightmare. And sometimes we end up with, a Bental procedure, what they call a root replacement. So procedure sequencing is very important in lifetime management of severe aortic stenosis. The other aspect of valvular heart surgery is functional mitral regurgitation. As a sequence of myocardial infarction, as you can see on the to see, but I'm sure you people must be able to see, it's a more a ventricular problem. The ventricle keeps on dilating, and there is separation of the leaflets of the mitral valve, and this is causing mitral regurgitation. So just doing a mitral valve repair by doing an annuloplasty does not solve the problem because the annulus may be reduced in size, but if the ventricle keeps on enlarging, the mitral valve will recur. Congestive heart failure continues to make the LV bigger, and this is a kind of a vicious cycle that is set in. Mitral valve repair is claimed to be associated with a lower 5-year mortality than replacement. No significant difference in rehospitalization over the follow-up period. Mitral valve repair should be the treatment of choice for severe MR and should remain a central aspect in valve centers, treatment algorithms, and quality improvement measures. However, mitral valve repair may fail, and we have to be prepared for failing because if the heart failure continues to increase, either because inadequate or suboptimal medical management and spherical remodeling continues, mitral valve repairs may fail. In that situation, mitral valve replacement offers a longer lasting benefit. Non-ischemic MR, of course, repairs are far better because it's a valvular pathology. It's not a ventricular pathology. And recently, pharmacotherapy in the form of ACE inhibitors or ARNI or vericiguat may prove to be valuable adjuncts in functional mitral regurgitation. Recently, we have the Mitra clip. This is a catheter-induced clip, which is introduced from the groin. We puncture the atrial septum from the right side, going to the left side, and you can see this is a clip which is advanced into the mitral valve, which is the leaflets are being separated. We try to catch these leaflets, and as you can see in the right side, instead of making a single orifice, we make a double orifice in the mitral valve. This, of course, is still very costly, and it's not becoming a regular procedure, even though I would say if there is a very sick patient, subjecting him to mitral valve surgery on pump, it would add to the risk. In such a situation, I would do off-pump bypass surgery and subject them to a mitral clip for their mitral regurgitation. But again, cost is an important factor. Of course, in some countries, insurance takes care of them. In India, it's still debatable how much of insurance will take care. Areas in cardiology where heart team approach results in benefit. Today, I've been able to talk to you only on coronary artery disease and calcific aortic stenosis and function situations also, where a heart team are available for all surgical options. And of course, I have just indicated where below 65, I think cardiologists should understand that surgical valve replacement is better. Mitral valve repair or replacement, as I told you, younger patients, replacement is better than repair because they will come back. Bypass surgery, left main bypass surgery is better. Even though bifurcation stents are done, we would say that bypass surgery is better. Triple vessel disease, especially in diabetics, bypass surgery stands to give a better long-term result. This has been tried out in many trials, especially in diabetes, requiring multiple stents. The long-term results with bypass are better. Closure of VSD, naturally, I mean, it can be done both by devices, and surgery. Surgery is better. Open aneurysm of aorta, if they are there, open repair in ascending aorta is much better than endovascular stent, especially with the recent techniques of putting chimney grafts into the coronary arteries. These are not as good as doing a Bentall operation or a root sparing, aortic valve sparing root operations. Degeneration of bioprocesses, either we can do a redo MBR or AVR, but what is preferred now, especially if in an elderly, is a valve in valve. Putting a valve inside a valve is easy, and this decision can be easily taken by the heart team. Of course, not by the patient and the family. In conclusion, ladies and gentlemen, science today promises a life expectancy of 100 years and beyond. Just chronological age is not a contraindication to cardiac surgery. Today, as surgical techniques have improved, multidisciplinary approach gives a better outcome to the elderlies with comorbidities, being recognized preoperatively, and appropriate elective methods improve postoperative morbidity. Patient priority and not patient preference should be the axiom. To conclude, surgeon operates, the physician cooperates. Thank you very much for listening to me.
Uh, Thank you, sir, for wonderful presentation. I would like to now invite the forum for question answers. I acknowledge the presence of Dr. Maria. She is from Philippines, the current president of CMAAO 2024-25. I also would like to acknowledge Dr. Anil. He's the president-elect for 25-26. We have Dr. Angelica, Dr. Muzuki from South Africa, and we have all other doctors over here. Dr. Ravi Naidu is joining in from Malaysia. So we open the question answers. Dr. Maria, do you want to make some comments? Are you muted?
What is the oldest that you have done for TAVR? I understand that most of the studies done on this procedure is really for the elderly. They are the at-risk population. Would you know the oldest that it has been done so far?
Well, I think, as I told you, the chronological age is of no significance today. It's a biological age that matters. If a patient at 90 is fine, he should have no problem in having either a surgical valve replacement or TAVI as the situation demands. But if a patient has got comorbidities, as I listed, frailty or unexplained situations, if you can go back to my first slide, I can tell you that is when the risk increases. Doing a patient of 90 years, I have operated on a patient who needed a aortic valve replacement at the age of 91. There was no problem. She went home. So I feel that, age per se is not a contraindication.
I think we should educate our patients also.
That was the idea. That was the idea.
Dukwa, you have a question?
Hi, thank you so much for the great presentation there by Dr. Mani. I'm sorry I cannot. I'm unable to activate my video at this point in time. But I just wanted to know that I saw the risk factors that you've identified. But I didn't see HIV, and I'm not sure if that is important. I'm asking this because I'm living in a context where HIV is very prevalent, and I just want to know how is that going to pose as a risk factor, especially in the elderly, because those patients now that are younger are going to reach that age, especially that you have alluded to the fact that they reach the age of 90. Added to that is the fact that some of them are, or all of them, most of them are on ARVs. And ARVs, they have a tendency of raising or causing deranged lipogram. So just wanted to know that. The other one was, I saw you talking about the body surface area instead of the body mass index. When you talked about obesity, if you could clarify on that. Thank you.
You caught me there. It was misspelled there. It was BMI more than 30. And as far as AIDS is concerned, I've included, along with viral hepatitis, any kind of blood-borne infections which can be transmitted. As far as HIV and hepatitis B, C, and E are concerned, it's more risks to the operating team. As far as we take precautions, we take multiple disposables, and I don't think today, if I'm asked to operate on a person with AIDS or person with hepatitis B or C, I will explain the risk to the patient. I'll take care of my team and myself, of course, gum boots and complete masking and all that. And we go ahead. We operated even during the COVID epidemic. We operated with a lot of protection, self-protection. And so all this is possible today because of the advancement. AIDS, if the prognosis, life expectancy is not very high, we would tend to avoid surgical valve replacement if it is a aortic stenosis and offer them TAVI. But if it's a young person who's got a good life expectancy, then we would offer them surgical valve replacement. No problem. As far as BSA is concerned, I do agree that was a mistake. It is BMI, not BSA.
Thank you.
So there's a question on the Facebook which says, is cognitive decline and a memory loss is a concern post cardiac surgery for elderlies?
Yes, it was when we were using the heart-lung machine. It was a problem, and thereby we believe that by doing it off pump, the loss of memory and cognitive problems are much less, and that is one of the reasons we tend to do most of the surgeries off pump in India. Of course, if bypass cannot be avoided, yes, memory loss is a problem, and some patients do come. There are techniques by which we minimize cardiopulmonary bypass, which I have already explained, combining it with off pump. But it is big. The cerebral edema is a documented fact, and even after a 1 hour pump run, MRI studies have been done which shows cerebral edema. And this can contribute to altered sensorium later.
Okay. Anyone else has a question? Dr. Anjali, you want to say something?
No, thank you. I just want to say again to Dr. Amani, thank you so much. It was very interesting. I recently had to defend in a case where the patient was in his 90s who got a TAVI because of one of these uh, problems that he had was, and he was diagnosed with anemia. And the patient then died afterwards, not because of the TAVI, but because the anemia was a myeloproliferative disease, and he then went into kidney failure. So, it actually, confirmed what you are saying. You need to look at your risk factors. So the operation was a success, but they didn't explain to the the other problems or the contraindications or the complications that they could have expected of this. So yeah, in a 90-year-old, it can still work. Thanks.
I think I'm not able to hear anything.
Dr. Anjali, can you repeat? I think the connection was a problem.
Thank you. Is my connection better?
Yeah, perfect.
Okay, so
Yeah,
Dr.
now
Ganesh,
I can hear.
thank you so much. Sorry. I just wanted to say I recently had a 90-year-old patient that I had to defend, or the family came to me for legal causes. And it was a patient that had a TAVI replacement. The TAVI was fine, but he unfortunately had a myeloproliferative disease, and that led to kidney failure. And no one explained that his tiredness and anemia before the TAVI was actually due to his underlying diseases. And there was then very unhappiness about the fact that he underwent surgery. But the surgery was fine. It is the fact that it was not communicated to the patient's family or the risk factors of that patient regarding his disease, and whether the TAVI was actually necessary for his anemia and his chronic fatigue, because it was related to other stuff. Thanks.
Yes, I have listed anemia as a problem in elderly, and we involve our physicians in this situation. And if we had picked up myeloproliferative disease preoperatively, we would have taken a legal clearance from them, high risk consent. We call this informed consent, that we know that we have myeloproliferative disease, and still we want to go for TAVI. So that only protects the physician, but nevertheless, it is a continued risk to the patient. I do agree. What you have done, we would have.
Dr. Mani, I know
Yeah.
we are covering a topic related to elderlies, but I think there are a lot of questions which obviously we can ask you to cover later in some other event. But I think there's a youngsters which is more concerned these days with the early heart problems, and people are not aware. They want to know how much blockage they have, if there everything is fine, if the pain is related to gas, or if this related to something related to heart. What about the young generation, and I think that we have seen even the early death, even 30s people are just having a sudden heart problem, and sudden heart attack, and so anything on that?
Well, we recently had the World Heart Day, and I had given a lecture on premature heart disease. I mean, we customarily think that heart disease should occur only after the fifth decade, but what we are seeing is it's in the third and fourth decades we are seeing heart disease. Maybe the stress of modern life is more. Maybe our eating habits are not very good. And the other thing is the desire to look very fit, and we over exercise, and this causes a strain on the heart, which is more than what the body can take. And the fourth thing, which is an X factor, is post-COVID. Patients who have had COVID, we have seen more patients having sudden heart attacks. Whether the COVID involved arthritis and that caused coronary arthritis, I really don't know. It's a research topic. Maybe you can take it up with some of the researchers. But yes, I do agree. We see more of youngsters coming forward with heart disease and sudden deaths and so on and so forth.
And is there a regular test people should do on an annual basis?
Well, I think a regular cardiological investigation of just doing a treadmill test and echo should suffice. But if there is any kind of a suspicion or a very strong family history, or I would say even patients who have had a tough COVID and got out of a ventilator, what is easily done is CT scan, CT coronary angio, especially today CT coronary angio is equipped with artificial intelligence, and there are softwares which can read very early coronary artery disease. Yes, I do agree. CT coronary angio is picking up, and a lot of AI is going into it.
Absolutely. So anyone else has a question? Otherwise, we'll close the forum. Okay. So I think, Dr. Mani, I think it was an excellent session and a very informative session. The session is live on video, so people can view it. Any closing remarks from your side before we end the session?
Well,
So,
I think I'm.
Yeah, Dr. Mani.
Go ahead. Go ahead, doctor.
Yeah, I think let me close with tributes to your dad, Dr. K.K. Agrawal, because it is his concept that medical education should be not only to doctors, but to the public at large. And he involved me and him, of course, he involved himself also in educating the public. If public knows more, like for instance, if the patient knows that TRAVI is not good for him in a certain low risk situation, then he won't ask for it. It is public education that is to be extended beyond just medical education of doctors. Thank you very much for this opportunity.
Thank you very much, doctor, for the opportunity to hear your lecture. At CMAAO, we are most grateful. Thank you very much.
Thank you.
So with this note, we will close the session. I have a very high regards for Dr. Ganesh Mani. Thank you for giving us your precious time and enlightening us with a great knowledge. And I think there are more sessions to come. So with this note, we would like to thank everyone for joining in. See you again.